I want to thank each and every one of our panelists today for just bringing us just outstanding high quality information, commentary. And I want to thank our audience for the fantastic questions that have already come in. I am aware of our time, so what I'm going to do is try to just get as many of these in as I can. If there are others, go ahead and send them in, but we do have a fair number in the queue. So I'm just going to walk through them. The first came in during our first presentation. So if Dr. Barfield, I believe this was directed toward you, the first question said, I have just recently learned that when we think of maternal mortality, that our data also includes statistics around abortion morbidity and mortality and other pregnancy-related phenomenon, not just pre and post birth. So this was just a clarifying question. Is that correct?
Yes, so the data does include deaths occurring during any condition related to pregnancy, so that can be abortion-related deaths, and we do monitor those deaths as well. They're still relatively rare occurrences, but we do also monitor them.
Thank you for that. The question that came in, so there were three during your talk, and I'll kind of walk you through them. The next was, what percentage of actual pregnancies are being captured in the CDC figures? That came in from John Birch from Mid-American Angels, trying to get a handle on what's the capture rate in terms of how the data are collected.
In terms of the total number of deaths that are occurring due to maternal mortality, pregnancy-related deaths. As far as we know, the data is pretty comprehensive nationally. However, it is important for us to note that there may be occurrences by which we may not be aware of a death that occurs incredibly early in pregnancy if information isn't linked in terms of a birth event. That's some areas where we really need to think about. And then there are possibilities that there may be some errors, for example, in terms of a maternal checkbox that may not necessarily accurately reflect maternal death.
Thank you for that. There is just one last one that came in during your talk that said, with regard to data sources, does the PMSS distinguish between deaths that are associated and those that are not associated with pregnancy?
Right, so that's a good question. So currently, PMSS focuses on deaths associated that are related to pregnancy. However, the maternal mortality review committees, and it depends on the jurisdiction, they can look at pregnancy-associated deaths, which include all deaths within a year after delivery, as well as pregnancy-related deaths. So again, it will just depend on the jurisdiction. One of the things that we have been learning from maternal mortality review committees in collaboration with understanding risks related to opioid deaths, we're getting a lot of information that may also be pregnancy-associated deaths.
Sure. Okay, thank you for that. The next one I'll open up to more broadly, though I believe it came in during Dr. Zeffrin's comments. It's someone who's stating that in their country, in Guatemala, that a number of the in-hospital maternal deaths are associated with postpartum hemorrhage and tend to occur over weekends and holidays, working days and night shifts, things like that. So I think she offered the question, are there data about timing with regards to maternal death in the US? And so I put that out broadly to anyone who has a finger on the pulse of our national data. Are there data available on the timing of it?
Mm-hmm. I can start, and Wanda, you may want to weigh in. I mean, there are data around looking at data around morbidity relating to blood transfusions or not, like how much, I mean, whether the morbidity or mortality condition had a blood transfusion related to it. But I'm not sure about specific sort of timing hour by hour. That may be hospital level data and systems level data, maybe at the level of a Q&A committee. But Wanda, you may have more to add, or Abigail.
Yes, so in terms of timing of maternal mortality as well as pregnancy-related deaths, we do have information about the timing of when those deaths occurred related to pregnancy. With regard to broader issues in terms of, morbidity and those events, I think that sort of wages a broader question in terms of what may be the underlying conditions that are contributing to severe morbidity. It may be that there are underlying conditions that were long-standing that really hadn't been detected until an event that sort of triggered a severe maternal event.
Okay, thank you. I think I'm looking at our time, and there are a couple that have come in from someone we already asked a question from. So I'm going to offer this one to the entire panel because I think that it's maybe where a lot of people's questions are. And of course, it just flew away from me with another question coming in. So it says there are limited data on how to mitigate health inequities. They parenthetically state that, there's the AIM bundles have lowered some of the rates in California, but there's still racial disparities that exist there. And so it says, which specific interventions would mitigate system challenges, and what policies would you suggest that would minimize the equity gap? I think some of you touched on some of that. So just in closing out this last minute or so, if you get to choose one or two, what would you really rally and advocate for?
So I would advocate for the ensuring of culturally based, community-specific resources and services. For American Indians, Alaska Natives, cradle boards, which were very specifically targeted and a cultural practice that was taken from us, actually meet, and it's a way of keeping a baby after they're born in their first year safe and sleeping. And it meets every recommendation of the Academy of Pediatrics for safe sleep. And so that is a culturally based practice that medical science is just catching up on. And it is one of the things, just as an example, but when you invest in community-based solutions and policy is driven by community-based solutions, that's where you see meaningful change.
Thanks for that. Any other takers before I pass the baton to my colleague for a quick announcement? Anybody else want to weigh in?
I would agree with Dr. Echo Hawk as she's talking about the issues of systems. And I think it is important to note that given the majority of deaths that are occurring in the later postpartum period, that we really do need to think about systems issues to really address maternal health overall. And we heard that from our prior speakers in the earlier session. So very important.
Yeah. Thank you all so much for your thoughtful comments. And I know that we need to close out our session, even though we would love to continue to discuss this. And I wanted to point out that there is a comment from Monica McLemore about that there are some of those data regarding timing. So you can put your attention to the chat if you wanted to try to look up that paper from Neil Shaw